Hello, I'm Michelle Levander, Director of the USC Center for Health Journalism. Thanks for joining us today and welcome to our Health Matters webinar covering coronavirus, the mystery syndrome afflicting kids. It's long been known that kids are among the most at risk for severe influenza or the common flu. And while COVID-19 has largely spared children, some have become seriously ill. Some sick kids already had underlying respiratory conditions, but what we'll focus on today is the emergence of a second mysterious inflammatory syndrome in largely healthy kids that has taken doctors aback. It can affect the skin, eyes, blood vessels, and heart, and trigger life-threatening medical crises. Doctors have named the baffling condition multisystem inflammatory syndrome in children, or MISC for short. Most children who develop it have tested positive for coronavirus or have coronavirus antibodies, yet doctors are still struggling to unravel the links to COVID-19. How can journalists understand and report on this mystery syndrome, which is truly every parent's nightmare? And what do policymakers and health practitioners and leaders need to know about the condition? Here to help us explore these topics, we're joined by two distinguished speakers. Dr. DiBiase is Chief of the Division of Pediatric Diseases and co-director of the Congenital Zika Program at Children's National Hospital in Washington, D.C. She holds appointments as a professor of pediatrics and microbiology, immunology, and tropical medicine at George Washington University School of Medicine and Health Sciences, and serves as principal investigator in the Center for Translational Research at Children's Research Institute. Dr. DiBiase treats normal and immunocompromised children hospitalized with severe infections. She leads the Children's National Ebola and Emerging Infections Task Force, and her research focuses on severe and emerging viral infections affecting pregnant women, newborns, patients with compromised immune systems, and healthy children. She has authored over 70 original research review articles and book chapters. And we'll also hear from Pam Bellick, a health and science writer for the New York Times. Pam has served as a Ferris Professor of Journalism at Princeton and frequently teaches and speaks about science journalism. Her extensive reporting from multiple continents launched the Times Vanishing Mind series about Alzheimer's disease and dementia, and her groundbreaking 2014 series, Mother's Mind, showed that maternal mental illness is much more common than previously understood. In 2015, she shared the Pulitzer Prize for Times coverage of the Ebola epidemic. That reporting was also recognized with an Overseas Press Club Award and American Association for the Advancement of Science Kavli Science Journalism Award. This webinar is offered thanks to the California Endowment, the Commonwealth Fund, and the National Institute for Healthcare Management Foundation, as well as by individual supporters like you. You could tweet about the webinar at the hashtag MISC. A word about our format today. We'll be hearing from our panelists first, and then we'll turn it over to our audience for questions. Because we have many people participating in this webinar, we'll ask you to write your questions in the control panel. You can also write us there or send us a message through chat if you're experiencing technical problems. And we'll be archiving this webinar at centerforhealthjournalism.org. Now let's turn to Dr. Biase. Dr. Biase, one of the first things we heard about COVID-19 was that children were largely spared, but then we started to hear about these cases. Can you explain what we're learning about the overall impact of coronavirus on children and how this inflammatory syndrome has focused our attention on kids in a new way?
Sure. I'm going to share some slides with you all so that we can dive into this and give you sort of an overview from a center that's been dealing with this now for the last 3 months. You know, it really is true that at the beginning of all this, it really seemed that children were largely spared even from infection, even perhaps less likely to get infected. And these initial reports from China, and even as it first emerged on the West Coast of the United States, really suggested that we didn't expect a lot of severe disease or even a lot of disease at all, mild disease in kids. But really, you know, the initial reports from China were about 2% of overall infections affecting children. But later when they look back and revise their data, it really does seem that it's up to about 12% of kids that make up the infections, not necessarily all hospitalized, but a larger proportion. And then the next thing we learned as we were preparing our response was looking very carefully at what happened on the West Coast in California and Washington State. And they essentially had the same experience that China had, with really very few admissions to the hospital and really only a handful of critically ill kids. We were on conference calls all week, every week, catching up with our colleagues across the critical care and ID realms. And there really wasn't a whole lot, but we still, maintained our preparedness, of course. But really what has emerged now in the last couple of months is that the experience we've had on the East Coast, and when I say East Coast, I mean DC, New York, Philadelphia, Boston, it's really been very similar when we talk to each other. And that in Europe has been markedly different from what was seen in China as well as the West Coast. So for instance, what I'm going to summarize here quickly for you is what we have seen as severe disease even before the emergence of this new phenotype, this MIS-C thing. So over this period of time now, we've tested over 5,000 patients in our lab, and about 10% of them that are symptomatic are positive, and up to 48% of kids in our ambulatory walk-up, drive-up testing site, which is a different population who have symptoms, are positive at peak circulation. So clearly there are a lot of kids that are infected. In our hospital, of those that we've actually taken care of, we've had 460 that have come to seek care, and 113, or about a quarter of those, have been sick enough that they needed to stay in our hospital. And of those, about a third have needed critical ill pediatric intensive care support, and about 2/3 have not. So they've been in a regular hospitalized situation. And just to give you a flavor of what's going on at our hospital, we have had continuously since this began anywhere from 8 to 17 patients that we need to be taken care of in full isolation. And then on top of that, the same number that are under investigation. So again, we need to take care of in a very isolated way. And then beyond that is the emergence of this additional now inflammatory syndrome, which came up later, and what we're really going to focus on, and Pam's going to talk a lot about. We've had 32 of those cases in addition to these 113. So we published an interim experience, and I'm just going to go over a little bit of it because I think it highlights really what a lot of centers now have seen in our publishing in the United States. And so what we did is we took the first 177 patients that were all of the patients that came to care, and about 133 of them were not hospitalized, but 44 were at that point. So this was about a third of the kids we've seen now. And we also wanted to compare the kids that were hospitalized who were critically ill versus those that were not, just to see if anything fell out. And what you quickly see is that the median age is about the same across all of the kids, but when we compare the critically ill kids, it really is the older adolescents compared to the younger kids, and this was statistically significant. We had distribution across all of the age ranges, but I want to show you here that what was really clear, if you look in the blue, is that the blue bars are pretty much the same size across all the age groups, meaning anyone who's infected. But the hospitalized kids clearly were these under 1 year of age, and then these over 15 year of age kids. And then when we switch to the green bars, which are really the sickest kids, it's really this older, over 15 year of age group. If we flip over to sex, it's pretty similar, male, female. And as far as underlying medical conditions in the regular old, what we are now calling, standard COVID infection, it was about 40% overall had some underlying medical condition, but that means 60% did not. But when we got over to our hospitalized component, it was up to 63% that had an underlying condition. And in our critically ill group, 80%. So clearly, if you had an underlying condition, you were more likely to get hospitalized or be severely ill. And when we looked at the specific risk factors, which have been reported a lot in adults, but really had not been looked at yet in children, it was our kids with neurologic disorders, so underlying cerebral palsy and other neurodevelopmental disabilities, that were overrepresented in the hospitalized cohort. And we also saw overrepresentation in our kids with congenital heart disease, with hematologic problems like sickle cell disorder, and our cancer patients. And I'm not going to spend a lot of time on the symptoms because I think that's beyond the scope of what this group needs to hear about today. So the big point I wanted you to take home there is that even before the emergence of this multi-system inflammatory disease, there really was a different experience in Europe and the East Coast, with clearly a lot of kids needing hospitalization and critically ill. Nowhere near the scope of what the adult elderly population saw, so we don't want to overstate that, but way more than what was expected from China and the West Coast experience. So this multi-system inflammatory disease of children, there's many, many case definitions starting in the UK and then in New York State, and this is the one that we've landed on here in the US by the CDC, but essentially it's very broad, purposely so that we don't miss people and as we learn more about the syndrome. And these is anyone under 21 years of age who has had fever for even just a day, has lab evidence of inflammation, and we have all sorts of markers that we can look at. They have to be sick enough to actually need to come into the hospital, and they have to have at least 2 organ systems involved and have no other diagnosis, and either have a lab evidence or a clear exposure to COVID. And what's become clear really in a very short period of time is from those initial 8 kids that were seen in the United Kingdom and resulted in that alert, and the case definition from there being released, Italy, France, Switzerland came out with cases, and then the CDC case definition allowed more people to recognize cases in the US. I mentioned our 32, but there are just in the last week multiple other peer-reviewed published series coming out of the New York City hospitals, both jointly and independently at Cohen Children's and Philadelphia, CHOP, and also the UK other centers. So this has really exploded in the last month. And like many centers, because it's a disease that crosses many disciplines for the diagnosis, we have a task force that combines our infectious disease expertise, critical care, rheumatology, cardiology, immunology, and we all meet and have a single email. So anytime anyone who's a referring doc out in the community thinks they might have one, or there's someone in the ED, even with a thought, we get a single email and everyone's alerted and we're on it right away. Because what we've also learned in the last month is there's a huge number of kids that probably come in before they get to that shock and critically ill state. So we have now seen what we call 3 different phenotypes of disease. And the one that really caught the media's attention was the fever and the Kawasaki-like kids, because they're very striking, the red eyes and the red lips and the red tongue and the rash. But really there are many kids that don't have all those Kawasaki features and really just have fever and severe pain in their belly before they go into shock. Or we have had other kids that don't even have the severe abdominal pain, but just come with multi-system organ dysfunction. And I'm just going to end on a couple of slides that tell you about our experience, which incidentally, if you look at the reports now coming out of the other centers, it's striking how similar we are seeing the same thing across all centers. So the median age is 9 years. So this is older than our typical Kawasaki patients. The age is, the sex is split between male and female. About 1/3 of the kids have been critically ill at our center. At some of the centers where this was earlier, there's a higher proportion that were critically ill, but I think that's a reflection of over time, we've gotten better at picking up the kids before they go into shock and can start the treatment to prevent it. Underlying diagnosis, as opposed to what I told you with the standard COVID kids, it's a flip-flop. So we clearly have more kids that are normal that are presenting with this inflammatory state, but there's still kids with underlying disease that do have this presentation. And our race and ethnicity data really matches what we see in our population. So we have not yet seen overrepresentation of race or ethnicity compared to the standard population that we have at our center, but there's a much more detailed analysis of that going on. This is also very similar to other centers. So we are seeing kids that are antibody positive, meaning they had previous infection and have made an immune response, that who are either currently having virus detectable or not, but at least half of our kids have an antibody that's positive. And then if we look at the kids that are actually still have virus detectable, it's about 1/3. But there's a lot of kids that have both. And it's interesting when we look at the viral loads, and maybe we can get into this later, even the kids that have positivity, it's more consistent with shedding at a lower level, which goes along with this whole concept that it was from an infection that was a little bit earlier. I'm going to skip over this because I think I don't want to spend a lot of time on the medical part, but this is one of the 3 types of kids that we have. And the point here is this kid is previously well, really just had a fever, sore throat, and then had really bad abdominal pain that got worse, and he went into shock. And we found all sorts of cardiac problems with this child who responded, thankfully, like most of the kids, to immunomodulation that was very aggressive. And fluid and critical care support. And I think I'm going to land on this slide, or I'm going to have one more slide that talk about the research gaps. But what we're really worried about in this new MIS-C group is not just the pulmonary long-term complications that we worry about in the standard pulmonary disease of COVID, because many of these kids that come in with MIS-C really haven't even had any pulmonary disease. They probably had an asymptomatic or very subclinical infection before they got re-exposed and then developed this immune response. And so in this interim analysis we did about a week or so ago of our 32, we actually had 38% of these kids really at the get-go already had some sort of cardiac abnormality. And I put a little picture here for those of you who aren't medical. You know, this is the heart, and these are the coronary arteries that supply the heart. There's three main ones. And this is an example of what we call an aneurysm, or a ballooning out of the coronary artery, which should be, you know, very narrow caliber. And this can eventually then go on to scarring and blockage of blood flow to the heart, and can lead to early myocardial infarction or heart attacks later on. And then this is an example of ectasia, where you have these little ballooning. So we measure the sizes of these and have standardized sizes, but a normal coronary artery should be nice and smooth and small. And these kids were picking up these abnormalities really early on, which is even at a higher percentage than we usually saw in the case of Kawasaki. So if we look at a Venn diagram, looking at kids who have depressed cardiac function, or meaning their heart's not squeezing well, or have a coronary abnormality like one of these things here, or have some fluid around the heart, there are some kids that only have the ballooning of the coronary. There's some kids that have an aneurysm with depressed function. There's some kids that just have depressed function without an aneurysm. There's some kids that just have the effusion. So we're seeing a whole lot of different combinations of cardiac disease. And this has been true across multiple centers. So this is the part I'm going to end on, you know, the knowledge gaps, because as we learn, it makes obvious questions come up. So, you know, what is the actual seroprevalence in kids? No one has done that study. Even the large cities that have done seroprevalence studies that have been reported out, they really have not focused on or included children to a large extent. So that's really a big black box and a very important one to fill. What is the rate of asymptomatic infection in children? What's the natural history of shedding? We see kids that stay positive for very long times, and we know this because they have to come back to the hospital and we have to rescreen them, and it's very low levels, but what is the implication of that? You know, are they infectious? Are they not infectious? What does that mean to go back to school or camp or what? And then the mechanism of this new inflammatory state is very important for many reasons, which we'll get into, but we're interested, and other people are too, of course, the genetics of the virus. Is it mutations in the virus? Is it something about the host that makes them susceptible to this inflammation? What are the specific pathways? So we're looking at cytokines, and then treatments. We want to have clinical trials to include the pediatric population. We're interested in outcomes. What are the implications for vaccine responses? And then how durable is antibody response or immunity to this infection? Could it happen again? So we're working on all of these things at Children's. We have a relatively large single center cohort, which we are going to characterize very carefully so that we can shed light on some of the questions to these answers. And we're also involved in coming up with novel treatments like T-cell therapies that specifically are directed towards SARS-CoV-2. So I'm going to end on our nurses, because they really are just amazing people that are in the room with these patients. And our kind of slogan at our hospital is positive vibes, negative pressure. And they're really just heroes at our hospital. So I'll end there and turn it over to Pam.
Thank you, Dr. DiBiase. One last question before we turn to Pam. With the country reopening and new hotspots emerging all the time, should we expect to see many more of these cases?
Oh, to me, I'm sorry. I thought you were going to turn it over to Pam. Yeah, I do think that we should expect to see more cases. And I think we're already seeing that in some of the states that have opened pretty rapidly. So I don't think we should be surprised at all at new cases. What we want to be careful of is how quickly are those new cases occurring, and monitor that so closely that we can then pull back when needed or put in other strategies if it's moving too quickly. Because for instance, you know, we were lucky in Washington, D.C. that we had some lead time to see what happened in other places where it was more out of control. And I think things closed down a little bit earlier in DC and Maryland, not because anyone's smarter or better at data, it's because we benefited from the experience in Europe and in New York. So I think it remains to be seen as things are just starting to reopen, and many places aren't only in phase 1 of reopening. We have to monitor this very closely, but we do expect to see more cases.
Thank you so much for this excellent overview. Now we're going to turn to Pam Bellick to talk a bit about the journalism and the challenges of reporting on this. Pam, how do you approach writing about children in the pandemic? And what are the different judgment calls you make in this rapidly evolving news environment? What's the threshold for writing about children?
Well, I think, in general, anything that we're writing during the pandemic, we've all been, any health writer here, has been faced with the challenge of trying to assess the, voluminous amount of science that's coming out, a lot of it, kind of preliminary or small case studies or not peer reviewed. And we've had some retractions recently. So we're all trying to be, my colleagues and I and others in the, are all trying to be very careful about when and how we write about something. With children, I think you have kind of a couple of extra layers to consider. You don't want to unduly alarm parents when maybe not all the information is in, or it's not quite strong enough. And, as Dr. DiBiase, pointed out so well, there are so many unknowns about particularly how this is affecting children, in part because there are a relatively small number of cases. And it's also been, it's a little harder to study children. They're not as always involved in clinical trials and things like that. So we have been trying to be careful about that. On the other hand, anything that happens to children is, just by its nature, so important and so resonant for people. So, and of course, if it's something parents need to be worried about, we need to alert them and we need to get this information out there. So it's been a real judgment call for us along the way. I've been doing, I guess, most of our coverage on children in the pandemic. And we've just tried to assess, is this a good study? Is it a large number of people? Is it, interesting enough or sort of credible enough that we think we should at least say that it's out there, with the caveats that that are important to point out. With this inflammatory syndrome, we were especially careful because it initially was reported just by virtue of an announcement in the UK from, it was a sort of an email that the National Health Service had sent to the Pediatric Infectious Disease Society. And the Infectious Disease Society had put out a statement in late April saying, we're seeing a few cases. It seems to be a slightly larger number of kids with inflammatory symptoms, but we don't really know what we've got, and some are testing positive and some are not. So in that situation, we decided to wait a couple of days and just kind of assess so that we didn't unduly alarm people. And then I got contacted by one of my sources saying, we're seeing the cases here in the US. And that's when we started, reporting in earnest to try to figure out what we've had. And then we did our first story a few days later.
And Pam, you have been reporting on this as a kind of real-time medical mystery that we're trying to unravel. How has your own reporting on children evolved since March?
Well, so in March, we initially had small studies, I think first coming out of China, then maybe simultaneously from the United States and Italy. And they were looking at what I sort of call the first strike capability of the virus. This is the respiratory assault. This is what adults are getting. And so we were seeing these studies that are saying, children aren't entirely spared. Some of them are getting very sick. So I wrote a couple of stories about that, trying to explain what was known about who was most vulnerable there. And that actually has evolved. Initially, some of the early studies were saying that infants and toddlers were the most vulnerable, but now we're seeing, I don't think we consistently know which age group is more vulnerable. Some, as Dr. DiBiase said, there are some older kids in their sample that they've seen are vulnerable to this respiratory assault. So we were trying to report on that. And then at the same time, I was trying to understand, well, why would it be that children are affected in this way and only a small number of them. Because one thing that's also really important here is that, and I think this is important whenever you're writing about really any kind of illness, it's obviously important to write about the majority of people who are affected. But the outliers are also really important, and often the medical breakthroughs come from studying the rare cases. And so, because if you can figure out, for example, why children are relatively protected, that may give you a lot of insight into the way that the illness and the disease process itself works, and that may help lead to treatments or vaccines, or at least better ways of understanding the condition that everybody else faces. And that, I think, happens frequently in medicine. So one of the questions I was asking was, okay, well, here are these relatively small number of children who are getting this respiratory assault. What's going on there? And we still don't really know. There are a lot of theories about maybe children have lower levels of a receptor on the surface of their lung cells that allows the virus to enter the lung cells and replicate. That may be, one reason. People have talked about maybe they have lower levels of proteins that are active in the disease. Some people have talked about theories about their immune system. All of that is, I think, still quite speculative, but I know there are a lot of people working on that. So that was kind of the tack I was taking in March and April. And then when we started hearing about this inflammatory syndrome, and it was clear that that was a whole new situation, not just because we were getting these very, heartrending stories of kids who had no underlying conditions, who were getting, suddenly desperately ill, and there were a few deaths. Obviously, it was important to alert people about that and try to understand it. Also, that it just seems to have a completely, it's a different effect. It's sort of a secondary effect. I think, and Dr. DiBiase could certainly, elaborate on this, but I think the thinking is that these children had sort of an initial assault an initial infection from the virus. Their bodies did what they were supposed to do. They fought off the virus, they formed antibodies, and they may have been asymptomatic or had very mild symptoms. None of them seem to have gotten very sick from the respiratory assault. But then later, sometimes weeks later, they ended up with this suite of inflammatory symptoms, falling into one of the three categories Dr. DiBiase was talking about. Some of them getting very serious heart complications, and some of them dying. So now the mystery has sort of turned into what is happening there, and what can that tell us, not only about how to protect these children, how to identify their symptoms early so that they don't go into cardiac failure, but also what larger lessons can we learn about the way the virus works, that can, inform other decisions that we're making.
And I'm wondering if you could kind of expand on, you've really spoken, very eloquently about the medical lessons potentially about kids, but what are the policy implications for studying and reporting on children about things like reopening schools and vaccine development? And this may be something both of you want to answer.
Yeah, I mean, exactly. I'll start, but those are I think two very critical questions. So, if we are going to, schools are going to reopen, and school systems are trying to figure out how to do this, and if you have children who are otherwise healthy getting this kind of latent response that's hard to predict, then that at a minimum should probably tell school nurses and school systems what to be on the lookout for any kind of initial symptoms, and not to pass them off as, say a stomach ache or something like that. So, I think at a minimum, it's giving schools something to look for. But, it just maybe also should suggest that we should be a bit more cautious about how quickly we reopen schools and how quickly we get back to kind of a normal classroom situation. With vaccine development, there are people who are interested in the idea that if these kids formed antibodies and it was the immune response that triggered the inflammatory symptoms, what can that tell us about how to make sure that a vaccine in certain children, doesn't produce that same kind of effect? So it's a piece of information that's really important for people who are developing vaccines to take into account. And I think experts in the field suggest that this is another reason why children should be involved in vaccine clinical trials at some point, so that we can make sure that that issue doesn't happen.
And Dr. DiBiase, did you want to weigh in on this at all before we go to another question for Pam?
Yeah, I'm also just going to pick up on something else that Pam said. The whole mechanism of the inflammatory syndrome, really, we don't know for sure. The first initial thing was, wow, is this just a different mutation virus? Like, is this some different virus? But, increasingly, we don't think that's the case because the kids really respond to immunomodulation, meaning we just attack the inflammation. And in our children, we have not given antiviral, even into the kids that have detectable virus, because the amount of virus that's there is much, much less than what we see in the kids that are coming in with the acute infection. And if you have an active, aggressive viral replication infection causing your symptoms, you don't just turn around with immunomodulation. So, and this is not just us, this is multiple centers now. So we don't think it's a different virus, although we didn't talk about this much, but there is a difference between the virus that circulated in Europe and on the East Coast and the virus, in China and the West Coast. So it remains to be seen how much of this MISC they're going to see on the West Coast. It hasn't been a lot yet, but we'll see what happens there and if that's a hint with the virus. But what I'm really interested in is, I'm convinced that it is an aberrant or overexcited immune response to the viral infection that happened before. But what I don't think we still know is it just you had your single infection that you didn't really get too sick from, and now this is sort of the leftover of that gets revved up? Or is it that you kind of got over the whole thing and then you got re-exposed to virus out in the community and like it's a boosted response? And to me, that's a very critical question, because that would have the most implication for how we design the vaccine. Because that's, what a vaccine is supposed to do is you make your antibody and your immune response, and then when you're re-exposed, you stop the infection. But I think we really want to really understand this immune response really well, so that we can make the vaccines safe. And I know we can do that because we've got fabulous viral and immunologists that are working on this across the world. But I think those are really key pieces. As far as going back to school, I think one, like I said it before, we have to know the seroprevalence in children. I mean, literally, it could be 0, I'm exaggerating. It could be way less than in adults. It could be almost all kids. We really don't know how many kids are asymptomatically infected. And there's many, many other examples of respiratory viruses where the presentation is different in children and adults. So we can't just extrapolate the data that we have, for instance, from New York City that was adults, and say, well, we know that's the percentage that are of kids. So those are studies that the health departments are all working on. We're working on that with our local health department too. But it's going to take a lot of kids to answer that question. And I think the reason I bring it up is, if you know that you've got 80% of your kids that are immune, even in a locale that doesn't have that higher percentage of adults, that has different implications for how you safely bring them back to school or not. Whereas if you have almost no one who has immunity, you may need to organize things a little bit differently. So, yeah.
And I want to turn for a moment from the science to the craft of reporting on this. And Pam, a lot of top-notch COVID reporting is excellent at elucidating the science. And then there's other reporters who are just natural storytellers and bring home the anguish of families, very movingly. But you've managed to skillfully interweave narrative and the science and create really compelling narratives. Can you share some of your strategies for how you make these stories come alive and how you find these patients and convince them to open up to you? They're children after all, so that makes it all of the more difficult.
Well, thank you. I guess it's always been very important to me. I've done a lot of reporting where I always try very hard to find people who are willing to share their experiences, ideally fully named, fully identified. So that just takes a lot of spade work and casting a wide net. I have certain strategies, I guess, that I use, or certain approaches that I use to, try to make sure that people are comfortable even before they sit down, and even sometimes before they agree to talk with me. Sometimes what I'll do is, if somebody thinks they might be interested, but they're not sure, they're a little uncertain, I will, say, well, let's just have a preliminary phone conversation. You don't have to commit to anything. Ask me any questions that you want to know, raise any concerns that you have, and I'll do my best to respond. And sometimes you'll have people, this is, children and adults who will say, here are the reasons why I'd be interested, but I would really not want you to share this detail or this thing about my life. And so we basically can have sort of a conversation about that ahead of time. And if it's not relevant to what I feel is necessary to tell the story, then, often I can say, oh, that's fine. That's not really, that might be something that's very, very private for you, but it's actually not relevant to the story that we're telling. So I do a lot of that, and I think that ends up, making folks feel comfortable. And then, I just spend a lot of time. I do a lot of listening. I encourage them to get back in touch with me if they think of something else, if they're wondering about something. It's the opposite of a hit and run process. It's a very communicative process. So I want people to, I feel like people are trusting me and the New York Times, and to convey their story in an accurate way. And that's a big responsibility that I take very seriously, and I want people to feel like we've earned their trust. So I try to I guess convey that. Did that answer your question?
Yeah, and also, people are talking about really complex medical conditions, and when they're experiencing them as either children or the family members, it's happening in a really chaotic time and stressful time. So what do you do to verify aspects of the family story? And I mean, are you getting their medical records, and how does that effort also maybe help you with the storytelling?
Yeah, I feel it's very important to, you can't just, at least I don't, just take the family's word for what's happening. It's, particularly if they're a large part of the story, or if you're going significantly into their case, you can't just take their word for what's happening medically, because, even if they have a high degree of medical literacy, they are perceiving it the way that it happened to them, and they might not have, they might have been alarmed by something that actually the doctors weren't that alarmed by, or they might, have missed something that happened that for doctors medically was very salient. So I always ask to either and I guess to, depending on the amount of time I have, I guess I'll ask for medical records, but I always ask to talk to their doctors and sometimes their nurses. With some of these COVID cases, you have just several stages in their medical experience that might be, in a kid's case, it might be first their pediatrician, and then perhaps they went to the ER, and then maybe they were in the ICU, and then they were in recovery. And so they may have had different attending physicians, nurses, kind of focusing on their case along the way. And I may not be able to talk to everyone at every stage, but I try very hard to talk to put all the pieces together in their medical narrative and to cross-check things that the family has said. And I do a lot of going back and forth to make sure that if there's something I don't quite understand, or if there's something that contradicts, or if there's some gap in the story that I've been told, I spend a lot of time trying to make sure that I have a good grasp of what's happened.
And just looking forward, COVID doesn't disappoint reporters in terms of always having a new story to report on. And we're looking at reopenings across the country, this idea of recurrent surges, and then that's the backdrop for the return to school in the fall. So what are your strategies going to be for covering this story moving forward? What are you tracking, and what do you anticipate as the stories of the moment going forward?
Well, we talk about that, constantly. I think we are, and I have a lot of colleagues working on a lot of different aspects of this in different departments, of course, and so it's an evolving issue. But we are looking at sort of some broad trends. We're looking at some things not to make sure that we highlight and that we don't neglect. For example, it's been, we and others have written a lot about the disparate effect of this virus on people of color and communities of color and low-income communities. And we want to make sure that this is something I've raised a lot in our staff meetings, that we want to make sure that we are exploring all the different facets of that and the reasons why that's happening and the consequences of it. And that, when, say, the most acute phase of the pandemic passes, what is going to be the legacy of that on those communities? And, so that's sort of just one broad area that we're kind of looking at. With children, there have been some indications, but I think, as Dr. DiBiase said, that the data isn't in yet, but there have been some indications in, I think, New Jersey and New York, that the child cases of the inflammatory syndrome have also disproportionately affected children of color, but we don't know whether that could just be because it's just the exposure in their homes, because because adults are also being disproportionately affected. So, that's another thing to sort of look at. In the context of also what's happening with children, I think there are big questions about the genetic studies that are going on. Is there that can help, us understand what are the kids that are getting sick, do they have some sort of predisposition? So that's something I'll be kind of interested in. There's just a lot of different, there's the science and there's the social impact. And I think that there's a broader kind of health system questions. And there are many of them, as you said.
Yeah, and I just want to share with everybody, we've already received a few questions in the, and there's a whole separate Q&A portion of Zoom. It's different from the chat. So please do go ahead and share questions for Pam, and thank you, Pam, for these great insights into your process, and for Dr. DiBiase. So I'm going to start, and maybe the two of you can just pop onto the screen with a couple of questions that we have already, and I'll invite folks to continue to share questions. So this is a question from Kate Smith for Dr. DiBiase, who asks, are there any signs and symptoms that parents, teachers, and caregivers should be aware of in children that are more likely to lead to serious complications?
It's a really good question. You know, the problem with this is, of course, there are many common, normal, not terrible things that cause fever, rash, and, you know, so I think this is the fine line that Pam's talking about, is we want to give people information so they're aware, but then temper that with the knowledge that the vast majority of these kids are going to be fine and are not going to have this terrible inflammatory condition. So the things that we have noticed, and actually this brings up another point before I get to her specific question, which is, you know, we are talking now about the most severe, right? The kids that are really sick, hospitalized, and even the ones that are critically ill. But in any disease, there is a spectrum of disease. And usually when we appreciate a new disorder, it's easy to pick up the worst ones first, because it's just hitting you over the head like, wow, this is something new, right? But once we get a little more knowledge and comfort and information, it becomes apparent very quickly. I'm making a little triangle here, that that's just the tippy top of the pyramid, right? And there's really a whole undercurrent of other people that are in that spectrum that are just not that sick. And I will say that, for instance, in our infectious disease clinic, where we get referred kids with prolonged fever. You know, this is one of the most common reasons kids come to infectious disease clinics for the last 50 years. And we have many long laundry list of things that can cause prolonged fever. Well, we have found lots more kids with prolonged fever that don't fit into one of the other boxes. And we believe that probably these are kids that also had a subclinical COVID infection and have a very minor over-inflamed situation that is not at all life-threatening or causing any of these things that we talked about. So the reason I give all that background is we don't want parents or nurses in schools or teachers to panic anytime a child has a single day of fever or even has a rash. It's really if someone has prolonged high fever, or if they are evolving into something else, like, you know, the child I didn't give you the full information on had fever and stomach pain. Well, that's the most common thing you would see with the child with a viral gastroenteritis. But the parent trusted their instinct and said, look, you know, it's day 3 and this is getting worse. It's not getting better. And now my child can't even sit up straight. You know, so it's gradations of things that people should be aware of. And I always tell parents and teachers to trust your instincts. You know, you see lots of kids, you take care of your own child. If this seems out of proportion to what you used to, we want you to have the knowledge that something rare can happen and that you shouldn't discount your concern. That's what we're trying to get across, but not that every time your child has any symptom, it's an emergency.
And this, your latest point really dovetails nicely with a question from Heather Marshall, who says, given the wide spectrum of symptoms and the severity of acute COVID and MIS-C in children, do you think it's likely that many more kids are getting some sort of post-infection reaction, perhaps mildly, but not leading to shock?
Yeah, and that's exactly what I'm talking about, that probably some of these kids that just have a prolonged fever, they're actually going about their life perfectly happy, but the family's like, look, I measured the temperature and it's 101.5 and it's been like that for the last 4 weeks. Everything else is great. The kid's happy, they're fine, you know. So obviously that's not a kid that's going to go into shock and you know, have a horrible thing. And the fever tends to go away, just like in any prolonged fever. But, you know, we haven't proven that yet, but this does seem to coincide now with the COVID epidemic. And some of those kids even did have, like, the whole family was sick, had a respiratory thing, everyone got better. And then this child is better, but just has these low grade temperatures that haven't gone away. So I think, to me, that's a manifestation of probably some prolonged inflammation. But you know, right now we have to focus all the attention on the sickest kids, of course, and that will give us the answers, like Pam said, to the mechanism. And then we can apply that knowledge to broader groups of individuals, both kids like this that have milder disease, but also the population at large. So, you know, if we can identify, hey, these are the actual immune cells that are involved in this reaction, and this is the exact thing that happens when those immune cells are activated, that is what you need to then figure out a good treatment, and also to figure out how to avoid that, stimulating that response when you make a vaccine.
And Pam, did you want to add anything on that one?
No, I think Dr. DiBiase did a good job.
So we have a question from David Eggleston, who says, to either speaker, if we live in parts of the country where there have been no identified cases of MIS-C, are there any precautionary steps we might want to take at this time specific to the risk during the general COVID-19 reopening phase? And I'll add to that that you mentioned earlier East Coast and West Coast, but you didn't mention, other parts of the country. Is that because there are no cases?
There have definitely been cases in the South, for sure. I'm aware of cases being investigated. I think it's in maybe 18 or 20 states. So there may be at this point kind of a concentration on the East Coast, but it seems to be following kind of the surge, if I'm right, Dr. DiBiase, right? I mean, in other words, the epicenter was New York and the Northeast. And so it stands to reason that the places that had the majority of cases would have, would also be seeing a spike in these cases. But that doesn't mean that if you see these, if the surge starts to move, as it has in some places, even places that are now seeing some increases after they've been reopening their economies, it's possible. I think we don't know that yet, but it's possible that we will also see the emergence of this in children there. So
yeah, and there's definitely been, I think it's up to 30 states now that have had at least one case, but I think the point Pam's making is this concentration of multiple cases so far has been mostly in the Europe and the East Coast. What I think has been really interesting is, for instance, going back to Washington State and California, I mean, they really had a significant number of cases, not a huge number of pediatric cases though, and they really haven't had a lot of the MIS-C cases. So it's interesting that even though they've had virus around for a while there, for instance, if there are a lot of kids that were subclinically infected in California and Washington State, and then this really is, if this is really a re-exposure phenomena, or, I would have thought we would have seen more of the MIS-C cases there too. So then it goes back to, well, maybe it's a little more complex. Maybe it is a combination of the type of virus that's circulating and the exposures and the right host. It's like the perfect storm of three different things that has to happen. And sometimes we see that in rare diseases, that it has to be a perfect Swiss cheese lineup model where you just happen to have all of these unusual things that all align. But that may be what's going on. But I think, the question about should they be worried as they, in the Midwest or places where it hasn't emerged yet, I think that, the main take home point I try to give to parents and families is the knowledge that something severe could happen, so that whatever they're hearing from friends and family that think this isn't really happening, or that it's, something that could just be completely ignored. I think that's the message that we want to try to counteract with some fact that, we don't have all the information yet. We definitely do have children that are ill and sick. It's not just kids with underlying disorders. So if you have anything you can do to mitigate the chance that your child will be infected, it's worth doing that, and not going to extremes, but, go ahead and wear a mask. Don't try not to get into a group of 85 people right now, simple things like that. And I think that's the main message. We don't want people to say, you can never go out of your house again, and this is going to happen to your child, because the odds are it's not going to happen to your child. But it can, and we want people to know that, so that they can take the simple measures to avoid infection until we have more knowledge and hopefully a vaccine.
And one of the things I'll just add that, has been so kind of rewarding and is a testament to, I think, the importance of what those of us who do health journalism do, is that, I've heard, personally from, I think, maybe half a dozen parents from all across the country, and I think even in Canada, who have said things like, I read your story and I understood what was happening to my child, or I contacted my child's doctor and it turned out that she did have this, and basically, this saved my child's life, or really helped us out. And so I think it's also that as Dr. DiBiase said, just giving parents some sense of what to look for if their child ends up being one of the relatively few cases. Gives them, it empowers them. It helps them understand what questions to ask their doctor, when to be worried, when not to be worried.
And we have a question from Esperanza Suarez. I know, Dr. DiBiase, you shared the demographic data for New York, or maybe even just for your center, but she wondered about the demographics broadly across the nation. Is this being tracked by the CDC in some separate place where reporters can access it for their region?
Do you know? I mean, I think you may know better than I do, Dr. B. I've seen a couple of states, other states besides New York. I think Louisiana and New Jersey, this is last I checked, which was about a week or so ago, had been reporting some demographic breakdown in children. But the CDC, recently said that for everybody, they're going to start reporting racial and ethnic data. So I hope that this will also apply to kids.
I actually lost the connection, so I didn't hear the question.
Oh,
but,
it was
I'm
where
sorry.
to get the demographic data more broadly. The reporter who asked it happens to be in California.
Okay.
On this, syndrome, basically.
Yeah. The demographic data is tricky, particularly for the racial and ethnic data, because, you can put raw numbers of this percentage, that percentage, but to really draw a conclusion about is there an excess risk, you have to do statistical comparisons to the actual So for instance, if I say 80% of children with COVID coming to our emergency room were African-American, you might go, oh, wow, that's way more than the population of African Americans in Washington, D.C. That's overrepresented. But then you have to look at the population of people that seek care in our ED. And if it's very similar, you can't say, oh, wow, that's out of proportion. So it's a little more complicated than just the raw numbers. So I think that's why it's hard to get that data straight off of a report from a health department. And it has to be taken into the context of the population. But clearly, from the adult data, there is overrepresentation of groups, and we actually have a similar analysis going on in our pediatric group that hopefully will come out soon. But it is a little more complicated than just looking at the raw numbers.
And Kelly Hardy says, in regards to the comment about schools reopening, that school nurses should look out for this, that we have basically no school nurses in California and we need more staff in schools. And I'm just wondering, to Kelly's point, is this the kind of thing, like so many other aspects of COVID, that's really pointing to some shortcomings in our public health infrastructure, and what your thoughts are on that?
Go ahead, Pam.
Oh, well, yes. Unfortunately, yeah. I mean, it is one of, I would say, it's certainly one, it's yet another thing that points out, the gaps we have, and that's been I don't know, maybe it'll end up being a positive legacy of this pandemic, that we learn the things that we need to have and we actually invest in them. But I think, you're right. If you're in a state with no school nurses, then parents should, I guess, pressure their school district to, I mean, I assume school districts are taking this into account, but there should certainly be a conversation about how their schools are going to be monitoring kids who may go to school perfectly healthy and then end up having symptoms at some point. What's the plan for that? They must have a physician on call. They must have something, right? So if they notice the kind of sustained symptoms that Dr. DiBiase was talking about, or if they notice anything that they think is worrisome, then they should not drop the ball. They should contact the parents, tell the parents to contact the pediatrician, whatever it is that's a good a good way of making sure that those connections don't get dropped and that they get acted upon. But yeah, it does place an extra burden on the parents, doesn't it, to try to make sure that their school is preparing appropriately.
And I think schools are just going to have a lower threshold for, you know, if someone comes in with a headache and even a slight temperature, they're not going to send you back to the classroom. They're going to send you home, and, you know, you're going to go see your pediatrician and get testing. Or hopefully someday we'll have these point of care tests that maybe it could even be done in the school, you know. So I just think people will just have a lower threshold for having someone evaluated, which is appropriate, you know, while we're in this phase.
And Roderick Malloy asks, in cultures where turmeric is a staple in children's diets, such as India, have you seen any different occurrences of MIS-C cases in children?
Well, I don't have specific data on turmeric, but I will say what's been really interesting again is that particularly when we looked at least a third of these cases are very Kawasaki-like and very aggressive on the coronary. And so there must be some overlap somehow in the mechanism of what we see with Kawasaki disease, and at least some subset of these MIS-C kids. You know, those cases are way over. Kawasaki is very prevalent in Asia and in, you know, Japan and Asia in general, and in Asian populations, and yet we have not seen MIS-C in Japan, Asia, and these other countries. So, you know, there's something beyond, it's more than a simple story, as most things usually are. There's probably multiple factors with respect to the virus, the host, and the timing of the infection. That's what I'm thinking, but, you know, we just don't know yet. But it's an interesting idea, you know, I'm assuming the question is, you know, are the known anti-inflammatory effects of turmeric, are they somehow dampening and preventing the manifestation of this inflammation? But I don't know any data on that.
And just wanted to follow up on that question with one from Margaret Nicholas, who says, what is understood about why the experience seems to have been different on the East Coast and in Europe versus on the West Coast and in Asia?
Yeah, again, we don't know for sure, but, you know, the things that we do know, you know, you look at the obvious things first. So it is a different virus strain. So that's being looked at carefully by people to see, is there a specific thing about the European strain or the sequence of the virus that's different compared to the China and Western United States strain that will induce a different response in the host. So like, is there, if you change this protein on the spike of the virus, does that now lead to this where it didn't in the other? So that, you know, that's the first question. And then there's the question just about population density. You know, is it just the Western coast? It's more spread out versus here, but, you know, China is pretty dense. So to me, I don't think that's likely the explanation. And then there's questions about the host. So, you know, is it the genetic background? Do we have a different mixture of genetic background here on the East Coast that's a little different enough than on the West Coast that could explain it? But we really don't know the answer to that.
And the genetic question is kind of interesting too, because as far as I know, this has not affected, you know, siblings, right? There, I mean, I don't know of any hospitals that have had, you know, had this happen in sort of, you know, in people who are genetically related. So if there is a genetic predisposition, you know, it'll be interesting. There's probably something else that's happening, right? Like you said, there's probably a perfect storm. There's probably something else about that child's physiological condition, or maybe their exposure, or maybe the way that they dealt with the initial infection that distinguishes, you know, their reaction and why they got sick from their brother or sister.
We have a question from Ed Cara, who says, has there been any data to date suggesting that this syndrome may be linked to a super antigen effect from SARS-CoV, as with toxic shock and strep staph bacteria?
I mean, I think people have looked at that theory for Kawasaki disease, so it makes sense to look at it for this as well. I don't think there's enough definitive data for any of these proposed mechanisms to make any conclusions yet about anything. But I do know people are looking at that. There's people looking at T cells, there's people looking at B cells, there's people looking at the antibody. There's some people looking at specific cytokines, which are the chemicals that the body puts out, you know, when the virus or the immune system is activated. So the answer is yes, someone's looking at that, but I'm not aware that it certainly hasn't been proven that that's the case, but I'm sure there are people that think that could be part of the story.
We have more of a comment from somebody, Linda Seltzer, who says there is a test, an electro-optical test for COVID-19 that is like a breathalyzer. It uses I'm mangling this,
Spectroscopy.
Yeah. And she says people just breathe in the tube and it has 90% accuracy, which I think is higher than our current diagnostic tests, if that's the case. And it was developed at Ben Gurion University, and that this could be used in schools. Is that something that you all are familiar with or would want to comment on?
I'm not familiar. I mean, I'm familiar with people that is our, you know, what we want is something that we can do with what we call the point of care, meaning you don't have to like stick someone or do a test and then send it off to a lab. Meaning in the office or in the school or at the home, you can do something, whether that's saliva or whether that's breathing into a tube or a finger prick. But to my knowledge, we're really in the early stages of what's called validating those tests. So you really have to do side-by-side comparison of what's right now the best test we have in the same patient at the same time, done at the same time to see what the head-to-head comparison is. And I'm not aware of a point of care test yet that has 90% sensitivity. I do know there are many centers working on them, and that's one of them, but I don't have specific information on that one.
And if I could turn to you, Pam, on this question, there are so many, you know, kinds of promises and claims, and some of them are very promising and others are not. What advice do you have for reporters when analyzing this sort of thing?
Well, I mean, I think it's sort of the, you know, kind of the general advice for good science reporting, but you know, maybe even more so given the stakes that we have here and also the flurry of information that's coming out. You know, try to see the data, try to, you know, talk to people who are, you know, not connected with the research, with the company, with you know, the place that's developing this, and but yet are knowledgeable in the field. You know, look for criticisms, I would say. You know, that's one thing I always do in my reporting is I always try to find, you know, credible critics of the piece of research I'm reporting on, so that you can, you know, be aware of what the potential flaws might be, and then, you know, try as hard as you can to, you know, to evaluate those. Also, I feel it's very important, again, maybe especially in this context, but always, to be very clear with the reader or your audience, you know, about what isn't known yet, what scientists don't know yet. And there's a ton of that, you know, so, you know, even just saying in the context of your story, you know, a few broad areas where, I mean, Dr. DiBiase and I have just sort of outlined so many things that are still unknown about just this one syndrome. And it's useful to be able to say, well, we don't know why, you know, certain kids are getting it, and we don't know exactly when they're getting it. We don't know whether it's you know, exactly what's happening physiologically. And so I think if you you know, are level with people about the fact that this is an evolving situation, people are trying to answer these questions, but right now we don't know, you lessen the chance that you know, that people will take it out of context and you know, jump on a new development as though it's you know, as though it's a holy grail or something that's, you know, definitely going to work. You just have to be very careful about the way that you convey something. And that goes for like the headline and how it's played on your site and all of those things.
And Heather Marshall asked a question that could really be applied for any adult in children's lives. I'm sorry, Mary Steckert, she says, can you both comment more broadly on your thoughts of transmission from children to teachers? But that could be true for children to parents or grandparents too, of course.
I mean, I think we don't, I guess I'll start on, you know, I think that's another question that I know there are, you know, definitely big studies that are trying to figure out both, you know, what the incidence of infection is in children, and what the likelihood of them being contagious. I think, you know, there've been different theories about are children more likely to spread infection to others? Are they less likely? I don't think we know the answer to that yet. I think the one thing we know is that they can spread the illness. It's so there is some risk to children being in a social context with anybody, other children, adults, just as there is with adults. And hopefully we'll get more information about that soon, because I think that's really important for all sorts of decisions, including what you're focusing on here, you know, reopening schools.
Yeah, I would agree. We just don't know, but I'll tell you, our inclination is actually, it may be the opposite, that it seems like, at least our kids that we've taken care of, it's more often that someone else was infected and infected them than the other way around, or they were in a household, you know, the adults were sick and then later the child. So, you know, my guess from and this is purely anecdote, is that I don't think it's the kids that are the main spreader, the source, but, you know, we just don't know the answer to that until we do much broader testing.
And we'll just ask you one last question here, which is what will be the barriers to enroll children in vaccine trials, given the likelihood of an immune component of MIS-C?
Yeah, I think, you know, enrolling kids in vaccine studies is always a challenge, even in any vaccine, because it always, you know, will usually start with a lot of lab data, of course, and then animal studies, and then adults, and then expanding to children. So, but I think, again, just getting at in a way, this response, which has been unfortunate in children, is a very good clue to look at specific other areas of safety that might not have been looked at that closely. I mean, all vaccines look at vaccine safety very carefully for general immune responses and allergic reactions and all those sort of things. But if you actually have something that you can look at and dissect, and then specifically take that information into the vaccine production ahead of time, that is a huge advantage ahead of time. But, you know, the challenges to children in any kind of clinical trial, whether that's vaccine or treatment or whatnot, there are many protections, and appropriately so, for enrolling children. But when it's important, we do it, and this will be one of those cases. So the many companies, as you know, are working on vaccines, and children will certainly be part of those studies.
Well, with that, I want to thank our two wonderful panelists for this discussion, and to thank all of the participants for their questions. We will be archiving this webinar at centerforhealthjournalism.org. You can also find Dr. DiBiase's slides, as well as some resources. And we'll be sending you a survey, and please do fill it out to tell us what you thought of this webinar and your ideas for future ones. And we just want to invite you as well to support our Covering Coronavirus series. You can just send a text to 41444 should you want to support this work. Thank you so very much, and have a wonderful day.
Bye.